Good morning. I'm still drinking my coffee, so I apologize. This is obviously the smallest coffee cup I've ever seen in my life, but I will take it. So obviously there's a lot going on right now in state government, but I wanted to be here because obviously I love Game of Thrones. I'm curious, the most important question today is how many of you have seen this series? I just want to make sure because some of my graphics are related. Okay, so those of you who have not seen it, dragons and fire are in my PowerPoint, so get ready. We have a little dragon already this morning, so that was really actually fun and therapeutic to put together. But no, I wanted to talk a little bit today because we have a lot going on in healthcare. And I'm curious in this room, how many of you have worked in healthcare for 10 years at least? Okay, 20 years, 30 years. Okay, how many of you can say that this is very true in everything you've ever done in healthcare? Yeah. I can tell you, I've worked in Medicaid at least for over 15 years, and it is always changing. It is truly the only constant in healthcare is change. And one thing I'm learning in my new role is how do we get our teams to really respond to change and to be okay with change. You know, staff want stability and they want normalcy in healthcare. That is nothing like what we're dealing with right now, especially today. It used to, it would be every 2 years we were doing something different in healthcare. Now we are doing something different every 2 to 3 months. Our team is constantly, in Medicaid at least, and I'm sure your teams as well, responding to changes, state and federal. So let's talk a little bit about what those changes are, just to kind of ground us this morning. You guys know more of this world than I do, so medical technology is constantly changing. Costs are constantly changing because of that. New ways of doing healthcare, advances in technology, they're happening lightning speed today. Also, very timely image here is technology and what we do online and how we share data. We have electronic health records. I think they're great, but not every provider does. It's a challenge at times, but we need them to communicate and to be able to actually manage care. With the cyber attack that we're going through right now, this is a very good example of how sometimes relying on that technology can flip us over overnight, and now we are back to scrambling and looking for manual ways to do things again. Population. This piece is really, I think, crucial and kind of the center of everything in healthcare, is our population keeps changing, right? The needs of our population keep changing. So many seniors now, we have so many more seniors today and needs around their chronic conditions than we've ever had. And that really affects our healthcare costs and also the way all of our hospitals and our healthcare providers have to respond. And my favorite, Tracy, I'm going to pick on you as our legislator today, but laws. Laws keep changing. So luckily at the federal level, it usually happens every 10 years. It's like a decade experience now that we're seeing major changes to Medicaid, Medicare, and our exchanges. But the state level, every 2 years, something is changing. Right when we get our feet going and moving on things, we are adjusting to new priorities, which is great. It keeps us moving forward, it keeps us on our toes, but often it can also sometimes back burner work that needs to get done to keep us ahead in state government especially. And last but not least, I feel like I can pick on judges as an attorney. Courts often change everything, right? So we think we know what we're doing over here on the laws, and then some decision comes down and everyone is like, what? So now we have to undo everything. And sometimes it's helpful, right? So we need clarity around what our laws mean, because often they are ambiguous. So wouldn't be a Game of Thrones presentation without a master dragon, but how many in this room feel like every day there's a fire in your email when you open it? Joy, I see you, yes. I feel like this, well, I would prefer to be putting out the fire, but often we're using fire to fight fire anymore with healthcare. When I open my email, I swear this dragon flies out at me. I know it is just hiding in there every morning. And I know many of you feel that way. And that is a really exhausting thing to keep up for us as well as our team. So how do we help them get there? And how do we have a positive, proactive experience in working in healthcare? So there's a lot going on in changes. I wanted to put down on this slide so just some big picture things that are going on that are really unique to Nevada and unique historically. And then I want to talk a little bit about context. I'm not going to talk about all of these today because that would be a very long presentation and you guys would all be asleep. But I am going to talk about the Nevada Health Authority today, as well as our federal changes that are coming, because those are the two that I get asked about all the time. Happy to talk about some of these other issues and items later. But aside from these two, we are rolling out for the first time ever in Nevada a statewide Medicaid managed care program. This is huge. It's about 70,000 people who have never dealt with Medicaid through a managed care plan. It's different for our hospitals in this area. There was a lot of fear around it. And I really want to give credit out to our health plans for actually going out there and meeting and sitting down in our rural communities with those hospitals and community partners. It really helped take the air out of the room, take the fear out of the room and help them come to the table as well. So I'm actually really excited about this rollout and really think it is going to make some changes for our rural communities in managing care and care coordination. We also have a public option rollout. I know that's a dirty word, or dirty words, but it's coming. 1/1/26, these plans will be, well, they're gonna be available this fall through the exchange. But luckily, the timing is interesting because we've had some record cost indicators in our market. Rates are going up and the public option really had to push those down. It was not easy, and I wanna give credit to our health plans for really working hard to get there with us. Prior authorizations. So my husband's a primary care doctor, and I'll tell you, this is his favorite topic at dinner, and it literally causes fights. I do not want to talk about prior authorizations ever again. Prior authorizations, they play a role, and an important role. Yes, there could be some abuse, right? We can always say that, but we do know there are things that don't always work well, right? There's no predictability around them. We don't know when we're going to find out. When is the paperwork going to end? It's taking away from care. So luckily this session, there were multiple bills on how do we streamline prior authorization? How do we make it easier for our providers? The one bill did pass. The governor even had a bill as well. The bill that passed gives us enough to really start to streamline that timeline for providers. It's a step in the right direction. Removing prior authorizations altogether, I would not support, and because honestly, it does help us prevent fraud and catch things that are not correct. And remember, those that are reviewing prior authorizations are clinicians. Often people think it's some health plan worker behind a screen who has no idea about healthcare. It's actually often a physician that is reviewing these claims. Medicaid Express is coming. I'll talk a little bit about that in a minute. That's one I'm really excited about. Children's Behavioral Health System Transformation Project. This is a community effort. Some of you in this room are working on this with us. As you know, in Nevada, we have a serious behavioral health crisis for children as well as adults. We are currently under a Department of Justice settlement agreement, and it has asked us, it's really put some parameters in place for us to work toward a different system. So in Medicaid, we are leading this effort, but it is not just us alone. We're working closely with our counties as well as our other divisions in the state. But this one is also really important, and then it's a huge lift on top of all the other things that we're doing right now. So let's put it in context of why, for our teams often, this might feel overwhelming, right? We are seeing record level costs in the market. No one can seem to answer that question when I ask why. Why are we double digits everywhere? Why is the market 17% and the private market 17%? Yes, there are subsidies going away. Yes, the public health emergency, but those costs are going up, right? How do consumers keep up? How do we as a state keep up? Managed care is going up. I have never seen in my career double-digit rate increases. We are facing that today. In Nevada, that is a challenge. And not that I don't want us to pay what we owe, but how are we going to sustain that from a revenue perspective? We have to look at what is going on and how do we start to bend that curve or at least plateau it. So this is something we're really looking at the Health Authority right now. Federal funding changes are happening. Public health has been changing, right? How are they no longer going to be getting grants? What does their new system look like going forward? And then obviously we'll talk more about the one big beautiful bill. And then state revenue questions always linger in Nevada. I feel like you could throw a dart at the wall and that will be maybe close to where we'll land every budget. I wish we could be more predictable in this state, but we can't because we rely on some state tax revenues that do change, right? Right now, some folks are saying state revenues are going to be fine, and some are saying, gaming is down, tourism is down. So there's a lot of questions around how do we make sure we have the money to pay the bills. And this is all happening at the same time that we finally hit our lowest record for uninsured rate in Nevada ever. After expanding Medicaid all this time, we are finally at 8 to 9%. That is going to go right back up, probably because of all the cost increases in the market. All right, so let's talk about the Health 30. We did it, we launched it, that's the end of the story. July 1st is when we went live, and someone said, how are you going to stand up an entire department in 2 or 3 weeks? And I'm like, I have no idea, but we will do it. It was kind of like RY2K at the state. Everyone was like, something big is going to happen, and then everything was just fine. We are definitely up and operational, everything is moving. We are working through things as they come up. But overall, our teams have been super great, and everyone is showing up and so super supportive. So what makes up the new health authority? There's a lot more to the health authority than just this, but I wanted to really point out from a coverage perspective, because truly the health authority is about taking all of our healthcare programs that the state manages and runs and purchases for under one umbrella to make sure we're aligned, efficient, scaling our resources, as well as purchasing and getting the best deal for the state. So the first one is PEB. It is our Public Employee Benefit Program. The second one we have is our Health Link, which, as you all know, is our state health insurance exchange. We also have Nevada Medicaid, which used to be Division of Healthcare Financing and Policy, so throw that acronym out of your vernacular. We are now Nevada Medicaid. Battle-Born State Plan, which is our public option. Hopefully this mic isn't cutting out, sorry. This Battle-Born Plan, again, comes online next year, January 1. So why do we do all this? Someone said to me, people are saying we just move the chess pieces, or it's just a restructure and more bureaucracy. But, I can see the point in that. But it really was a strategic effort, and the governor really felt strongly that we need to bring things together because we're all working on the same things. All of these programs struggle with cost. All of these programs struggle with their vendors and procurements. They also struggle with workforce, ensuring that we have an adequate healthcare workforce to meet the needs of the members. So bringing them all together just makes sense. We're not the only state to do this. Often people talk about Washington and Oregon, but actually Kansas is doing this and actually doing it really well. So as a governor, I think the governor said it perfectly in his State of the State, that it's really about getting that strong purchasing power and using it to the best of our ability to get a better deal for Nevadans. So we've outlined our vision and mission and values. I will just say, I think most health authorities say healthcare is affordable, quality. We really felt strongly that the word reliable matters, and that actually is the hardest thing. You can have affordable health insurance all day, but if someone can't rely on it, that they're going to get care, who cares, right? So that is what we're working on. So we put reliable in there for that very reason. And we're doing this by looking at that buying power I talked about, looking at how do we streamline our programs, and how do we leverage our pharmacy team across all of our programs. Is a good example. And then also driving better quality and innovation in our healthcare system, often with our managed care companies, our carriers, or our providers through various payment models. And obviously our values are public service. I feel like those two words really sum up everything that we do. And then obviously fiscal discipline is key. We can build all this, but if we can't pay for it, that also doesn't matter, right? And then accountable leadership. So this is my new team. Some of them you've seen before. I'm very proud of this team. I could not do the work that I'm able to do without them. They keep me honest, keep me on my toes, and they're very good at what they do. Sandy has been in state government for a long time, and she's probably the best, I would say, at IT and really enterprise, looking at what can we do from a technology standpoint. She's one of the best in state government, and I hope she never retires. So I'm working to keep her. I am still looking for a chief of staff. Lynette Aaron is our financing deputy. We took all of the budgets that we could from a healthcare financing perspective and put them in the director's office. This bucket right here, these four, are our director's office. Melinda, many of you probably know Melinda Southard. She's actually a chiropractor, so we call her Dr. Southard sometimes. She is over our community engagement and workforce development. And this is a big thing that's going to be coming up with those rural health transformation grants. She is your person on that. Todd Rich, who used to be at the Division of Insurance, he is now with us. I always tease him, he joined the dark side and came to Medicaid originally. He is over healthcare purchasing and compliance, which includes our licensing division for facilities, inspections, medical laboratories, and other health-related services. Jennifer is over consumer health services, which includes our exchange, Medicaid eligibility policy, so the system that people connect to coverage, as well as our public option. Nick is actually stepping away from the interim role and back into operations, and Teresa Karsten, who some of you may know, is now, she was over managed care before in Medicaid, and now she is the executive officer of PEB. Very excited to have her there. Ann Jensen, I think a lot of you know her. She's our new Nevada Medicaid director. I've never felt happier to hand off that role to someone. Obviously, it's one of the hardest jobs in the state, I think, at times, but I know that she has exactly what she needs to do the job. Strategic goals. So these are our goals at the Health Authority. We decided we need to lay out some goals to how we're going to get there in the next 3 years. And then from that, we are creating what we're going to call a business plan. I feel like every time we have a strategic plan, it gets put on in a big binder and then put on a shelf and it just collects dust, right? No one looks at it. So we're doing a business plan. We're going to treat it like business, and we're going to really think about what are our strategies to get here. So on the right here, we have Nevada scorecard. Anybody surprised, curious, raise your hand if you are, that we're in the bottom 10 for everything in healthcare? Anybody surprised? Anybody in this room think it's not partially part of their responsibility? Everyone in this room owns this. I own it, you own it, we all own it if you work in healthcare. We have to do better, and we have to really say this is unacceptable. That is why it's our first goal, is to say we are going to move up Nevada. If we could get to 30s, hallelujah, right? Like, I will take 30, 39. We have got to get out of the bottom 10. We are 51st right now in mental health access and outcomes. We are 51st in care quality. That's at the hospital level too. And prevention. We are 49th in coverage and access and availability. We're 41st in maternal health. So we have to take this seriously, and that is what we're going to do. We can't do it alone at the Health Authority. It's going to require partnerships with all of you, as well as our other agencies at the state. The other second thing we're looking at is how do we make our programs sustainable? We want good programs, but how do we fund them, and how do we make sure that we don't ever have to unroll all the good that we're doing? So that is really important. And then 3, obviously, I think everyone in this room is trying to work on this in some way, is really our state's healthcare workforce. How are we meeting the needs of the community? We don't have enough providers. What are we doing about it? And then driving better value, coordination, innovation in our state, which also, as you know, gets those numbers up. So in my mind, a lot of this feeds those numbers up. So you might say, Stacie, that's really ambitious. Here she goes again with big ideas. But you know, we do have a big footprint in Nevada Health Authority. We cover 1 in 3 Nevadans across all of our programs. So if anyone is going to have an impact, it should be us. We can get there with our providers and partners. We just have to really focus in on that coordination and partnership. We cover almost 1 million lives. We also cover 1 in 2 births. I take that really seriously and realize we are part of the problem. We have to do better. If our rates are so low for moms and babies with mortality and morbidity, Medicaid plays an important role in that, as well as these other programs. So how do we get from here, where we're at today, to there? And this is something our team is constantly talking about. So we've decided to not get so stressed about all the work, but really think about it as reimagining coverage or reimagining healthcare in this state. We need to use more technology, modernize what we're doing. A lot of the stuff we do in state government and our programs is still manual, right? It's still paper. Drives me crazy. We have to move out of that and into modern technology. AI is there. Yes, there are risks around AI, and I'm sure Andrew in the back is getting nervous as I speak from fraud. Andrew knows that I am also afraid of AI, but how can we use it and how can we be smart about it and cyber aware, timely, and cyber safe? All right, so for those of you that know a provider or are a provider, I'm sure you resonate with this picture. My husband, I feel like this is him. This is how providers feel right now, right? And so when we're trying to reimagine healthcare for providers at the health authority, we're trying to think about what today feels like for them. They often feel like, how many more forms do I have to complete? How many more times do I have to get a denial? How can I get this patient care? It is frustrating because when they signed up for healthcare to be a healthcare provider, they didn't sign up for all that, right? They signed up to care for the people that they want to care for that come to their clinics. So we have different quality metrics too. I hear about this all the time. Our FQHCs are like, I have to do this quality measure and I have to do that quality measure. And I know the health plans feel that way too. Across all these markets, we have Medicare, we have the private market. We even forget often about the group market. That's the majority of coverage in the state. That market we can't touch, not yet. I'm working on it, no kidding. But we have to think about how do we align these things so that actually what we're doing is not just monitoring a problem or reporting to report, that it actually makes sense and we're moving the dial. Something else is credentialing. This stops people from actually providing care. Some people don't want to come to our state because it's complicated. Credentialing is a nightmare. They have to do it like 10, 20 different times depending on the market. So Medicaid, we're already working on that and centralizing it into one process. We want to think about doing that broadly for everyone. That's something I want to bring next session. Especially for PEB and where we can in the private market for exchange, where we can be helpful on that. And I just want to give credit to our health plans and the Medicaid side. They have come to the table and have been willing partners on this, which has been great. I really think not every state can say that. I used to work in Minnesota. I didn't want to always say that. I feel like our health plans here do come to the table and want to simplify this process. Many ways to enroll and contract. I mean, the list goes on, right? So where do we want to be? We want to be here. We want our happy providers, right? We want them feeling like they're supported. So what we're thinking about at the health authority, and it's going to take us time. This is not going to happen overnight. We may need to change some statutes. We may need new funding, vendors, but we're trying to figure out where we can now streamline and then create a one-stop shop for our providers for our 4 coverage programs. And really think about one enrollment process that really gets them at like a quality status to be in all of our markets, one credentialing process, same quality and value-based payment programs across markets. And where we can align with Medicare, we will. Same reporting standards, same forms and timelines for prior authorizations. These are the things we want across all our markets. Now, it won't be easy, and I'm sure that for the health plans in the room, they're probably like, oh my God. It's okay, we will get there together. It will take time, but we are working on it. So what about Nevadans? So when we think about reimagining healthcare for our Nevadans, I feel like this image is so true, right? Anyone who's ever tried to sign up for health insurance, it is a nightmare. I feel that way. And I run Medicaid. I feel like I know a lot more than most people. It is not fair that it is so hard. The other thing that I think is really real in this state, and we hear it from our hospitals, especially in our rural areas, is stigma. Get away from the welfare side, it's stigma. It is health insurance. Medicaid is health insurance. Public employee benefits are health insurance. The exchange is health insurance. It should not feel like you have to go into an office in your rural community that says, hey, I'm poor. Hey, I need help. It should feel like you're shopping for health insurance, and that's where we want to go. Forms are complicated, as you know. No real-time eligibility. Sometimes people wait and wait to find out if they're eligible. There's no shopping, especially in Medicaid right now, so they're going to have 5 options in some areas in Clark County next year. Right now, if we continue what we're doing, they just get a list of plans in alphabetical order. Good luck, right? Can you imagine a working mom trying to figure out, like, I got to go to this website and write all this in and figure out where my providers are? It shouldn't be so hard. They should be treated like anyone else. They should shop for their health care and know their networks and quality of their products. The other thing I think we could do better, and this is nationally, is when people are moving across markets, if these are the same carriers across markets, Why aren't we trying to make sure we're handing them off so they're not like, whoa, now what door do I go to, right? Unless you're an employer coverage that's really good, you're trying to figure out which door and where to even start. The exchange really gives us a good platform, and that's why we're moving to what we're calling Medicaid Express. So Medicaid Express is going to be what we're calling our one-stop shop for coverage. If you don't know, you just come here, plug in your information, the computer does its little thing and tells you, hey, you're eligible for exchange coverage and a subsidy. You can pick from these plans. Or if you're eligible for Medicaid in Nevada, hey, you may have no-cost coverage, or you're eligible for no-cost coverage right now. Here are your options. Real-time eligibility, real-time plan selection, and enrollment. That is where we're going. I'm very excited about this, as you guys can tell probably. We're working really closely now with the exchange and trying to figure out how do we lift this. This is going to take us probably 1.5 years, possibly 2. My team says don't push them too hard, so I'm trying to be very patient, but this is where we want to be, and this is where we should be. People should be able to access their health care. It should not feel like it's stigmatized. All right, last but not least, we are focused in on healthcare purchasing. It doesn't sound very sexy, I know. Purchasing for me is like the biggest thing that we do as a state. We buy a lot of services. We spend a lot of money on our vendors. Some of them are really good at what they provide, and some we struggle with. So how do we do a purchasing strategy across all of the carriers in our markets that really align things for providers and consumers, but also look at leveraging the money that we know is on the table, right, in our state? So in Medicaid, we're looking at $18 billion over the next biennium, right? So about $15 billion of that is Medicaid managed care. That's a lot of money, a lot of money. How do we leverage that to get a better deal for the 70,000 state employees who still can't afford their health insurance, right? So what are we doing? So we're looking at those strategies and putting together a statewide purchasing strategy. And we'll be rolling that out over the coming years. It will take time too, and of course every attorney's got to look at it and make sure I haven't gone too far. But we will get there, and I think it really will make a difference. And it also allows us to scale our resources across these programs. If we have 1 or 2 actuaries that we use instead of 4 or 5 different actuaries, right? If we have, 1 pharmacy program that's supporting all of these programs. So we're looking at things like this. All right, so let's dive into the more other things that are going on in context to all the exciting things we're doing in Nevada. I wish we could put a bubble around us right now and be like, please don't do anything to us. We are busy working. But these things are coming. So as you guys know, the One Big Beautiful Bill Act passed July 4th, or was signed on July 4th by President Trump. It has several changes in it for Medicaid, Medicare, and the exchange. I want to focus in on Medicaid today because it's probably the most significant from a budget perspective, but also just historically the changes that are coming. Work requirements for the first time ever are required for adults without children. There is some confusion in the community. Please help me to spell it. It does not impact parents. It does not impact children, obviously. It does not impact people with disabilities. These are only for our expansion adults. Now remember, expansion adults were the folks that we didn't really cover back in the day before the Affordable Care Act, but when we covered them, we got their costs covered 90% by the federal government. So while it makes, I think what they were trying to do is save money, or obviously have people have personal responsibility, but it's actually a budget problem. We lose 90%, right? It affects our supplemental payment programs, and we'll talk a little bit about that in a minute. Cost sharing for adults, we're still adults without kids, we're trying to figure out how this is gonna work with our providers. It's gonna be hard to charge them anything. If we do $2, $5, it's sometimes more expensive to operate something like that than the value of it, right? So we're looking at how do we do this that's not harmful for people trying to get health care, but actually keeps people accountable to maybe keeping their visits, right? We often hear from our carriers and our providers, they don't show up. Often that's because of childcare. Often that's because of transportation. So what do we do? So we're not penalizing them now with a fine. Freeze on provider taxes. For those of you that don't know what these are, yay, just put this aside, you don't have to worry about it. But it's a very big deal for our hospitals. Skilled nursing facilities have provider tax programs that they benefit from, they're exempt. Hospitals are not exempt from these changes. These changes are going to reduce billion-dollar supplemental payments to these hospitals, and we'll talk about that in a minute, and that is probably what you hear most about in the community. So over here, I just wanted to point out, in Nevada, according to Kaiser Family Foundation, 2 in 3 of our recipients do work. So that's good news, but how do we make sure that that paperwork and what they're doing about working, we can recognize, right? I would note that work requirements, there are exemptions for people that are in treatment for substance use. There's also, hopefully, we look at our medically frail definition. Hopefully that includes, we can make sure that includes mental illness and things of that nature. Private hospitals are going to be impacted by about $600 to $800 million loss in supplemental payments. It does not impact the budget. So that's good for us, but not good for the system, right, from a state perspective. So I just want to point out, though, putting it in perspective, this is a lot of money, but this program, so this is our baseline here in the blue box, right? We have 2 scenarios. We have one's our 600 million scenario and our other 800 million scenario. Right now, this is what they would have been getting otherwise in both scenarios, over $3 billion by the time this goes into effect. And remember, $3 billion, it's not full net gain. It's definitely a little lower than $3 billion, but that's the total payout to the hospitals. With the whatever we're calling OBBBA or OBA or triple B, this is going to lower that, right? And we don't know how low that's going to go, but they're still going to get money. They're still going to be getting over $2 billion. So that's the good news, trying to find our silver linings. I know that's not perfect because we have to spread this money over 45 hospitals. But it is still the silver lining, right? It's not all gone, right? And remember, this money has only been on the table for the last 2 years. It's a provider tax program that we set up 2 years ago. So this is not taking us back decades. It doesn't mean it's not going to harm the investments that were coming in our state, but we're not going back too far, right? So I want to put some context around that. I'm not saying it's not a big deal. I just want to remember it's not all gone. All right, so Chip, I just wanted to point out, our adult population is about 30% of our population. We are the 3rd or the 4th highest for adults without kids in the country that are covered by Medicaid. So when you look at the impacts, it's probably going to be felt pretty strongly, the work requirements in our state. All right, let's talk about budget. Sorry if your eyes are glazing over. This is, trying to put this together in a way where it was simple and easy and maybe even a little fun. So hopefully this helps. So for this biennium, good news, the impact is negligible. We can absorb it. It's not over $3 million, which I know for some people that may seem like a lot, but in our budget, it is not. We can absorb it. Next biennium, we have updated numbers since we last reported. We had we have had 3 actuaries help us look at this. And our third, and I think after consulting with the others, really we all kind of came to agreement that there is a range in the next biennium of about $95 million to $135 million budget impact. Again, in the scheme of the budget, it could be negligible depending on this biennium and how we're doing. It's hard to say. Obviously, these are preliminary and they will change once we get federal guidance. We haven't gotten any federal guidance yet, and it could swing things or it could lower it or increase it. But this is our best guess right now. So for work requirements, over 100,000 people, we think in the first year will be ineligible, probably mostly for paperwork and burden, but we will work to help them get jobs. We are going to put together in our Medicaid Express an option for them to find employment supports and resources. So we are going to work hard to make sure they know how they're exempt if they are, how to get exempt, and then also how to find a job. So I wanted to kind of explain work requirements. It is actually a cost and a savings, right? So not having to cover people saves us money, but there are people that will go back on Medicaid through the disability route because today they are not. For those of you that don't know, there's traditional Medicaid and disability Medicaid. Traditional Medicaid, they can have incomes up to 138% of poverty. That means they don't have to truly impoverish themselves like people on disability Medicaid. Disability Medicaid, which has more services, not everyone needs them and it's more expensive, they have to go down to around 70 or 80% of federal poverty. They have to truly impoverish themselves to keep their services. That is kind of the dirty secret. And by the way, that's the bucket where seniors have to go when their Medicare doesn't cover what they need. So we are looking at this as also being a cost. That is why it's not a total win in terms of savings. Provider tax reduction, it is a cost, so that this little guy here means cost if it doesn't show that. This is going to be a cost to our budget only when it comes to the children's behavioral health care. It will reduce the pot of money we have from the provider tax, but it won't reduce it all down, right? We can manage it, I think, within the pot that we still have if the tax program remains viable for hospitals. Premium tax revenues, this is something maybe some of you are not aware of, the health plans are. Everything they spend in healthcare is taxed by the state, 3.5%. That money goes back into our state general fund. It doesn't touch Medicaid at all, but we match that money through the health plans. So we're getting a really good deal. So when they're spending, which we do think because of all of this changes, as well as supplemental payments that go through managed care plans today, this is going to go down. So that's where you really get the bigger impact to the budget, is our premium tax revenue is going down. All right, last slide, I think. Trying to end on a happy note and a Game of Thrones note. There's a new nest egg, hopefully it's not a dragon, coming to our state soon. Hopefully next year we'll know more about it. Or whether or not we get the money. We at Nevada Health Authority have been designated by the governor's office to lead this effort. We are getting, there was funding in the federal OBA bill that gave states funding for rural health transformation. It was clear from the presidential summary about this program, and I'm sure it will be in federal guidance soon, which could come as early as 2 weeks, that it is about hospitals that were affected by the cuts to the supplemental payments. Now, it doesn't mean others can't get that funding to support hospitals and the infrastructure and healthcare, but we have to be careful as a community that it doesn't become a slush fund for things that it shouldn't have been. So I feel very strongly that we are going to focus in on making sure our infrastructure in our rural communities is solid. It's a 5-year grant. If we don't get it, we don't get it. We have to apply and get approved or denied by December 31st. And if any of you have ever done a federal grant, that is lightning speed. Just to get yourself registered at CMS to submit a grant takes 6 months sometimes. So I don't know how we're going to do this, but I will remain patient. Public requests, right now we are in a public comment period around this. We sent out notice before the cyber attack, thank God, and we used a survey. So after this, I will send that out to Diego, and so you guys can all have that link as well. We're collecting feedback right now on what we should use the funds for. It's really important if you do give us feedback that you remember this is not like ARPA, where we're just going to hand it out and see fiscal cliffs. That is not what this is about. This has to be sustainable, and it has to have a funding stream. I don't want to hear, oh, I'll get it. No, we can't have that again, because it's putting us now as a state in a predicament of not being able to sustain these programs. So think hard about infrastructure, one-time funding that is needed, as well as things that we know we can get funding for ongoing. And then again, we're waiting for federal guidance. All right, and so with that, I will end. The most important thing to know in Nevada, is not maybe in Vegas, but in Reno, that winter is coming. And I'm happy to take any questions, and really thank you all for being patient through this long presentation, and thank you for having me.
Is there any questions? All right, we have a question.
Okay.
This one will get us all started.
All right.
We do have to wrap up around 9:40.
I know, I went long.
Everyone knows.
I'm just gonna say you didn't really give me a deadline on time. Okay, what's your question?
Hi, Stacie.
Yeah.
First of all, great presentation.
You want to use
Thanks so
this?
much.
Yeah, I can't hear you.
Thanks so much for the presentation. Glad you're at the helm, quite frankly. And so my question is, the federal government estimates that the cost due to waste and fraud along the lines of electronic health records is between like $750 and $935 billion annually. Do we have a number for that for Nevada?
Okay. No and yes. I would just say that some of that savings doesn't go back to the state. It goes back to the hospitals or healthcare system. Often, I'm looking at Andrew, my buddy, at the AG's office. Thanks for coming, Andrew. But I would just say, I will say that it takes so much time to recoup from fraud. We often lose the money, we never get it back. There is not that much money here for Nevada. We are already got a really amazing team at our agency that is looking at this, as well as working with Andrew and his team. I would think we're one of the better states that are already addressing this. Andrew probably can't give specifics of the fraud, but it is widespread. And it's a provider fraud. It is not recipient fraud. That is rare. I just want to be very clear on that. So I would love to see a lot of savings on that, but I'm not hanging my hat on it.
Thank you.
Any other questions?
Hi, thank you very much
Yeah.
for the presentation. I feel like we made progress in the past with getting those Medicaid individuals the ability to get access to care. Obviously, when they lose that access, it's going to be a burden on the hospitals to use ERs as their primary care, and then that's just a thing. In a vacuum, it looks like we're reducing the number of resources or dollars.
Mm-hmm.
In terms of the entire budget, is there opportunities to look at other programs that might supplement this instead?
No. No. Sorry. Not to be Debbie Downer. I'll just say, Tracy knows this too, I'm picking on her again. Our budget's limited. In some states, yeah, they're going to have subsidies, state subsidies available, but we don't have a lot of revenue. I mean, we all love not having an income tax, right? We all love it, but this is the reality we live in Nevada. I will say this, though, on that point. I think when it comes to work requirements and people we know that need health care, the challenge right now is in the federal bill, there is a provision that says you cannot get exchange coverage if you also do not qualify for Medicaid because of work requirements. That's not good. So how do we help people? And that's going to take us with hospitals, social workers, helping people figure out how they get that job, how they get a actual exemption that's real, right? A lot of these folks we know today are our homeless population. They're transient. They don't make a lot of money. By the way, we have a big population on Amazon and Walmart. Okay, so how do we help them qualify? So those are the things we're gonna have to work on together and making sure. That's why I love the Medicaid Express. If someone finds out they're not eligible, they don't just get a form that says bye. They get a notice that says, hey, here's what you need to do. Go to your doctor and see if any exemptions apply. Get a note. Or here's some employment resources at the state and also on Google, right? Here's some jobs that are available that you may qualify for. That's what we're working on. So, and it's going to take us working together, but yes, the burden will fall on the hospitals. There will be charity care, indigent care program that we have in the state. Those things will be affected. Any other questions?
Right here.
Oh, sorry. I should have seen you in the blue.
No, thank you.
Yeah.
I guess my colleague and I, we're both providers.
Mm-hmm.
And this is just an innocent question. How do you come up with the fee schedule, the reimbursement? Because if you want to decrease the cost, you start with us.
Fee schedule, I'll be honest, I don't control it. The legislature does. It's based on our budget. I always tell people Medicaid's not a bank. Suzanne Bierman, my predecessor, used to say that, and I loved it, so I stole it. We're not a bank. We don't have money unless we're given it. So our fee schedule is often based on what the legislature provides. We will recommend a fee schedule based on market or what we see in other states. But what is actually funded is how we set the fee. So when people come to me mad about rates, I'm like, hey, then make sure, and I'm going to go on my own little rant here. Bills that go through the legislature that require us to add rates that are not funded because there's all these savings, guess what? Your rates will suck. You need to fund the programs that you ask us to pay for. So that's how the fee schedule is actually set. Now there are cost-based rates for some providers. Those are not easy either. You may think everything you do is the cost that should be reflected in your rate. Under federal law, it's actually not true. Only the salary and benefits of your staff are actually truly part of the rate. There are some exceptions depending on the provider, but it is a challenge. So it's always about funding. I hope that answered your question. Okay, follow up.
I guess it's a two-part question.
Okay.
How realistic it is, because I'm a physician, she's a physician, okay? I actually lose money if I see a Medicaid patient.
Mm-hmm.
They're very complex, very sick because they're underserved, okay, because they have insurance for many reasons. They take you twice as much of the time, if not 3 times. And if any one of you is willing to see a patient, a Medicaid patient, for $100, please raise your hand. And the second thing, why are we subsidizing Walmart, Amazon, okay, with our tax money?
Okay, so the first question, yes, I agree with you, but I don't have enough money to pay you more. The legislature's got to fund more, right? Those are rate increases, and I'll tell you, rate increases in Medicaid are $400, $300 million for providers. I hear you, I would love it, but we don't have income taxes. I'm just gonna say, so we have a budget, problem that we're dealing with, and that's a challenge. So, and I appreciate that you do serve Medicaid, so thank you. The second question, under federal law, large employers, I want to say they're still penalized, I'm not sure on this, but they don't have to provide everyone full affordable health care coverage. Often these folks may be part-time, and so they're not making enough from Amazon or Walmart or wherever the large companies are. We have a report on our website about this. Or they actually are getting coverage, but it's not actually affordable under federal law, so they qualify for Medicaid. So.
There is a way to fund it. I mean, just by giving me that tax expensive, just like you do in the hospital.
Yeah, talk to your legislator. I can't do anything without the law, so. But I hear you, and definitely that's why I raised it. So thank you for your questions. Anything else? Oh yeah, Jerry.
We very much appreciate your simplification initiatives. One of the complexities that providers deal with are all of the administrative complexities and with the billing codes that are in the thousands, etc. What are the successes either that our state or other states have done at implementing payment for outcomes as opposed to payment for activities?
Now you're speaking my favorite love language, value-based payments. A lot of states have had success with these types of models. We just are not as far along here because we lack the ability, to be honest, HIE or EHR to really share data. That's a problem. We have to actually deal with it at some point, guys. But we can pay outcome-based payments. We can do, actually, instead of code-based, we can pay you for a population in a capitation payment model. And you take risk, upside or downside. Sometimes we can do just upside, where you get savings from that if you're able to manage the cost of that population and you have extra money. You can also we could also do downside risk, and we should for some of our larger entities. If you're not, then that's on you, right? A lot of states are doing that. We are not, because of the data and our inability, I think, to really look at that data. A lot of states, hospitals especially, have population health management teams, full teams. We don't really always see that here. So I would love to get there. And we are working on that with our managed care plans on Medicaid side, which again is 1 in 4 Nevadans, so it is a bigger pool. And we're doing a quality collaborative with our hospitals to look at how do we drive some of these things, like maternal health, behavioral health, or anything of that nature. So our managed care plans are working on that, but it is a challenge on the data side.
I was wondering, have you looked at the cost shifting that's going to occur if revenue decreases for the hospitals? Are they going to cost shift into the group health plans, and they're going to cut insurance? The overall effect on the healthcare community.
We have an actuarial economist that's working with UNR on that. There is an impact to jobs as well as the healthcare economy. I don't have those numbers with me, but we are looking at it. There is an impact. It kind of puts us back a little bit back to where we were 10 years ago, or 15 years ago, whenever the ACA passed. It depends on how many people stay on and fall off. That's going to be the key indicator whether or not things swing and cost shift. Oh.
Hi, Stacie.
Hi.
Thank you so much
Yeah.
for that. My name is Dr. Atiba Kim, a family medicine doc. So quick question. There is this statement right now being put out that the way that we're going to bring more doctors to our state is by increasing Medicaid payments. Can you clarify how that will bring more of us over, especially with some of the challenges my colleague and I have? Thank you.
Thank you. We increased a lot of Medicaid payments around behavioral health. Bye. Thanks to you guys. around behavioral health care. And so and we did that specifically because we do have a pot of money from the provider tax for that. So we were able to actually do that piece. We're not funded for anything else. I will tell you, increasing provider rates is not like a one shot, we're done, it's gonna fix the problem. It's a bigger issue. It's around administrative burden, it's around credentialing, it's all the things we were talking about trying to simplify. But I think rates do help get our patients served. I don't necessarily know if it's going to attract new providers. I hope that answers your question. Any other? Okay, sorry, you had one earlier.
I just wanted to say, thank you for all the hard work you're doing, because you are making a difference, and all of our issues to deal with and help you. And so when we see that slide about where we fall and where we rank in the country, we all have different expertise within our field, and so I'm offering, if there's anything, as I have a credentialing background a long time ago, if you put any work groups or anything together, please reach out.
Okay.
I'd love to help.
Thank you, I appreciate that. Anything else? I'm looking to see how we're doing on time. Okay.
I also want to thank you for all the effort you guys are putting in.
Thank you.
I don't know if everybody recalls, old guys like me do, but prior to the Obamacare, there weren't 800,000 covered under a plan. It was Medicaid back in those days, covered maybe a couple 100,000?
It was around 300,000 or 400,000.
So all those revenues have gone to the provider community as a general rule. They'd always like more. I'm a provider guy, but it's been a big improvement over the years.
Yeah, and just to remind people, that $18 billion, only 2% goes to our operations. It all goes to providers. So thank you for pointing that out. I appreciate it.
Hi, Kelly Morgan. I'm an emergency physician, and you guys heard me a couple months ago on opiate grants and putting together better systems of care. Do you guys have a plan for kind of what Jerry was talking about with value-based metrics and care packages, basically around some of the things that we struggle with in Nevada, such as substance use? I know we talked about why we can't get adoption of opiate programming in the hospitals because we can't get buy-in because they're not getting reimbursed or they don't see the value. And so I'm wondering if you guys have a kind of like a work group that you're going to put together around some of those.
A lot of that right now is being spearheaded by each of our MCOs. Now, I think we could put together a work group to really streamline it. So I'd be happy to follow up on that and flag that for Ann. I think when it comes to substance use and behavioral health, value-based payment designs, they're hard to be upside or downside risk. So that means it's challenging because that population is so high risk and costly. We can't punish you because of you know what I mean? So the other things we can do is pay for performance, incentives. Those are things that we would be looking at. So I just want to be clear on that. Yeah. You were thinking that too?
Yeah, it was more around like why we can't get buy-in for things like substance use navigators in hospitals and sustainability for those kinds of programs.
Yeah, we need to actually add to our Medicaid program substance use navigators so that way they can be covered. So thank you for that plug. Thank you. Any other questions? All right. Cool. Well, thank you guys for having me and everything. Thank you.
Thank you very much.
My name is Ron. I work for the elderly industry care home group home.
Okay.
Do you have cards or something?
I love them. I was so frazzled with the
I'll just ask it
cyber
from
tech.
Sonny.
I'll email you.
Yes, please. If
Yeah,
you
I
want
will.
grassroots information,
I would love it.
how
Thank
to,
you. Echo.
hopefully help policy and stuff like that.
I love it. Thank you.
We'll be more than happy to help.
Thank you. I appreciate that. Thank you. No, I sit all day. You sick.
Information on co-management. We've been working with them on our workforce pipeline. We're now in 10 high schools, so we finished the year in 7. We're now at 10. By the end of the year, we're hoping to be in 20 high schools, starting those feeders into the post-secondary educators. We will be going over that. Please take the sheet or take a picture of it. I figured with Adrian, I was like, no, we can leave one. Maybe take a picture of all the events that we have coming up to be able to support.
I'm surprised you were so young.
I'm actually 45.
That's what I'm saying.
Oh, yeah.
I thought you'll be like in your 60s or so.
No, I'm going to retire by then.
I would like to take the time to recognize that every time I talk about Game of Thrones, people, there's like a confused look that comes in their face. I think, let me explain. I didn't make it right. She was the first one to like fully buy in. She
you.
Thank you very much. We hope to have you back, and let us know if there's anything here in the South we can do to support your work.
Thank you.
and serve our community.
Thank
Thank you.